Welcome to our video on torches infections. Let's get started. The word torches is an acronym of multiple pathogens that cause congenital abnormalities. It was initially proposed in the 1970s as torch. Over time, however, there have been some slight variations. The only part that is difficult to remember is the other category, which refers to Zika and Varicella zoster. But our goal is to help you comfortably recall all of these. So with this in mind, let's begin with the letter T in torches, which stands for Toxoplasmosis. A mother can acquire toxoplasma by exposure to undercooked pork, which is the most common route of acquisition. Additionally, exposure to cat feces can cause maternal infection. Fetal infection by toxoplasma occurs transplacentally, and it results in a triad of symptoms. The first finding of this triad is diffuse intracranial calcifications. Please notice that toxoplasmosis is characterized by diffuse rather than periventricular calcifications, which is in contrast to CMV. The second finding of the triad is hydrocephalus. And the final finding is chorioretinitis, which is an inflammation of the choroid and the retina. Treatment of both the mother and the neonate is with pyrimethamine and sulfadiazine. Here's an image which shows intracranial calcifications and hydrocephalus, which is classically seen in congenital toxoplasmosis. Hopefully you can appreciate the diffuse areas of calcification, for example right here. Also, you can see a dilated ventricle right here, which is suggestive of hydrocephalus. Here we see a neonate with hydrocephalus, and hopefully you can appreciate the dilated ventricular system and a relatively larger head size. Here we see a fundoscopic image of chorioretinitis in congenital toxoplasmosis, and pay attention to these exudates on the retina. Okay, let's move on to congenital Zika syndrome. Zika virus is a flavivirus mostly transmitted by the Aedes mosquito bite. Sexual and vertical transmission can also occur. One of the most specific neonatal findings is subcortical calcifications. Please, again, pay attention to the fact that these are subcortical rather than periventricular or diffuse calcifications, in contrast to CMV and toxoplasmosis. Other findings include ventriculomegaly, microcephaly, spasticity, and ocular abnormalities. Here we can see an image showing a neonate with microcephaly, and hopefully you can appreciate a disproportionately small size of the baby's head compared to the body. The diagnosis of congenital Zika syndrome occurs with either reverse transcriptase PCR or serology. Treatment is mostly supportive. Shifting gears, let's talk about varicella zoster virus, or human herpes virus 3. VZV is acquired by pregnant women via air droplets. Fetal manifestations of congenital varicella include skin vesicles, skin scarring, limb hypoplasia, hydrocephalus, and seizures. To prevent a VZV infection, pregnant women should avoid infected individuals. The VZV vaccine is contraindicated during pregnancy because it's a live attenuated vaccine. If the patient has not been previously vaccinated against VZV, she should receive the vaccine after delivery. However, if a pregnant woman is exposed to VZV during pregnancy, then she should receive a post-exposure prophylaxis in the form of varicella zoster immune globulin. So far, we've discussed the T and O. Now let's move on to the R in torches, so rubella. Rubella is a togavirus. It's transmitted via air droplets. Maternal manifestations include a fever, rash, arthralgias, and post-auricular lymphadenopathy. Fetal manifestations are commonly characterized by a triad, including congenital cataracts, a patent ductus arteriosus, and sensorineural hearing loss. Here we can see an image showing bilateral cataracts in a neonate, and take note of the bilateral opacification of the lenses. Now we'll talk about Cytomegalovirus, or human herpes virus 5. Routes of maternal CMV acquisition are sexual contact, saliva, urine, transplant, or blood transfusions. Maternal manifestations include nonspecific mononucleosis-like symptoms, such as a fever, pharyngitis, cervical lymphadenopathy, and hepatosplenomegaly. As for the fetal manifestations, the single most important finding is periventricular calcifications. Congenital CMV might also be accompanied by a seizure, a blueberry muffin rash due to dermal extramedullary hematopoiesis, sensorineural hearing loss, and nonspecific findings like hepatosplenomegaly and jaundice. This is the classic appearance of the periventricular calcifications in congenital CMV. Pay attention to these white deposits next to the ventricles indicating a high calcium content. Here we can see a blueberry muffin rash on the baby's skin. As we already mentioned, the blueberry muffin rash is due to dermal extramedullary hematopoiesis. Moving on, let's discuss herpes simplex virus. HSV, either HSV1 or HSV2, can cause congenital infections of the fetus. HSV is usually acquired via exposure to vaginal secretions during vaginal delivery. It usually causes diffuse vesicles on the neonatal skin. However, dissemination is possible, and disseminated HSV infection commonly involves the CNS, and it can manifest as meningoencephalitis. Here is an image of the vesicular rash caused by HSV in a neonate, and hopefully you can appreciate these vesicles over the baby's scalp. Now let's talk about prevention of HSV. If the mother has a history of previous genital herpes, she should be on acyclovir suppression therapy from 36 weeks of gestation until delivery. If at that time of labor there are no genital vesicles or prodromal symptoms like burning and itching, the woman can undergo vaginal delivery. However, if there are genital vesicles or prodromal symptoms, then the woman should undergo cesarean delivery to avoid neonatal herpes infection. Okay, let's move on to the last topic, the S in torches, so syphilis. Syphilis is acquired by the mother via unprotected sexual intercourse since it's a sexually transmitted infection. On the other hand, fetal acquisition occurs via transplacental transmission. Neonatal findings of congenital syphilis are very specific and pathognomonic for this condition. These include snuffles, which is nasal discharge, and ragades, which are angular scars at the corners of the mouth. Additional findings are a saddle nose, notched teeth called Hutchinson teeth, and mulberry molars. Finally, newborns with congenital syphilis may have a short maxilla, bowed legs, and sensorineural deafness. Here is an image of the snuffles in a neonate with congenital syphilis, and take a note of the nasal discharge. We can also see ragades, which again refers to angular cheilitis at the corners of the baby's mouth. This is a classic appearance of saddle nose deformity, and take note of the depressed nasal bridge. Here we can see Hutchinson teeth, and hopefully you can appreciate these notches on the teeth, for example, right here. And we can also see the mulberry molars in this image, for example, right here. Maternal infection with syphilis is best prevented by using condoms. Treatment for syphilis in pregnant women is with intramuscular benzathine penicillin G. It's very high yield to know that even if a pregnant woman is penicillin allergic, we should first desensitize her to penicillin and then administer an intramuscular dose of benzathine penicillin G. This is because penicillin is proven to be the best agent against syphilis. All right, let's wrap up with a review question. A 2-day-old girl is evaluated for rhythmic bilateral upper and lower extremity movements. An electroencephalogram reveals a generalized seizure. She was born at 39 weeks of gestation to a G2P2 mother who had a fever, sore throat, lymphadenopathy, and hepatosplenomegaly in the second trimester of her recent pregnancy. The physical exam of the neonate shows a head circumference at the 97th percentile. Fundoscopic exam shows bilateral retinal exudates and edema. An MRI of the brain reveals diffuse parenchymal calcifications. What is the best treatment option for this neonate? All right, this neonate has a head circumference at the 97th percentile, which is consistent with macrocephaly. In this case, her macrocephaly is most likely due to hydrocephalus. She also has bilateral retinal exudates and edema consistent with chorioretinitis. Finally, her brain MRI reveals diffuse parenchymal calcifications. The triad of hydrocephalus, chorioretinitis, and diffuse intracranial calcifications is consistent with congenital toxoplasmosis. The treatment for congenital toxoplasmosis is with pyrimethamine and sulfadiazine. And that concludes our section on torches infections.